Cornea being the most anterior part of the eye usually suffers the maximum blunt of the trauma. I do not have any financial disclosure in this talk. So, whenever actually we have seen the primary site of injury in the cornea, most of the people have reported that is from 53% to 81%. The cornea bears the maximum blunt, as I told you before. And following this trauma, it may be a small abrasion, or it could be a foreign body, small foreign body on the cornea. After removal of this foreign body, or following any type of trauma, they can develop into an infective type of keratitis. So this is one of the most leading cause of infective keratitis, as we see in most of our patients. The prevalence of corneal trauma in urban area, as reported by some authors, that it is 2.4%. But when you go to the rural area, the commonest trauma to the cornea is with the vegetable matter. And as you know, the vegetable matter is such a dangerous offending agent, it might lead into the fungal keratitis. So that is another dreaded complication of this trivial small corneal foreign body or abrasion of the cornea. The spectrum of corneal trauma is such that it is widely variable from a minor abrasion foreign body to complete disruption of the globe or rupture of the globe. And the rupture of the globe may lead to complete loss of vision, that is negative PL. So when you go into the global impact of this ocular trauma, the minor trauma to severe trauma, almost 55 million people suffer almost in day-to-day life, and it restricts their normal day-to-day activity. Out of which 1.5 million people go blind, either one eye or in both eyes. So this is just few example I have given you. And regarding the terminology, I'm not going into the detail of the terminology. It is widely variable, but most common terminology that is used for the ocular trauma is the Birmingham eye trauma terminology. This is widely accepted, but it has got some lacunae also, because this mostly cover with the mechanical trauma. They don't go into the other aspect of non-mechanical trauma. Other classification, considering that Birmingham eye trauma terminology, other terminology also came up from different trauma societies. Some of them are accepted, they are still in the process of modification. Like Ocular Trauma Society of India has formulated one terminology and classification that is also in the process of further clarification and going on into further modifications. Now I am going to give this an introduction to the instruction course. So I am going to give you a little wide spectrum of the corneal trauma that you see in our day-to-day practice. This is a small abrasion you can see localized in lower part of the cornea, and this can be inflicted by anything, and sometimes even such a minor thing patient usually ignored, and they come with a fulminating type of keratitis. Now here you can see there are three cases where you can see a corneal foreign body along with the infiltration. The top right, that one, first one on that side. You can see a small iron foreign body here, and this is better visualized with a little indirect illumination. And you can see along with that there is rustring. Now in such condition, if you remove foreign body and forget about the removal of the rust ring, it might produce some sort of delayed problem with the eye, like the siderotic changes may take place, though it is rare, but it can happen. Then you can see a small insect sting or bee sting lying into the corneal stroma. So these are the few minor trauma that we could see in the cornea in our day-to-day practice. Besides that, you might be seeing some of the problems with the contact lens wearer also. Then when you just pass on to this thing, you can go into a other type of, major type of corneal trauma, that is the corneal laceration. Corneal laceration could be a lamellar type of laceration or a penetrating laceration, and this laceration could only be restricted onto the cornea, or it can extend into the limbus or beyond that. So repair of this condition is very important at an early stage, and first time repair is always gives better result. This is the case of mine blast, and this type of conditions are normally seen in war injury or in cases of the terrorist attack. This is very common these days, particularly in some country where they are suffering from this type of trauma. Now, another problem that we come across in the cornea is the chemical injury. This is a non-mechanical injury and is the commonest one. Chemical injury varies from minor degree to major one. That will be covered by Dr. Namrata Sharma. And corneal laceration will be covered by Dr. Rajiv. And we are expecting other speakers to come over here. So they are going to cover whatever I have given you in the introduction. Now, thermal injury commonly seen in our country, particularly during the festive season or during some social functions. You can see there is a lead burn along with the surface burn of the cornea. This condition is relatively better as compared to the chemical injury because this is mostly a surface injury. It can be tackled in a better way as compared to the chemical injury. Now, this type of trauma, sometimes we ignore, we do not just take care of these problems. Like blunt trauma, they may not be detected at early stage, but finally they may come with some major problem like persistent corneal edema. Then you can have the Descemet membrane detachment following any intraocular surgery, particularly associated with the phacoemulsification or other form of cataract surgery. Then another complication you can see over here, that following removal of pterygium, the mitomycin C was used, and you can see the perforation with the mitomycin C near the limbal area. So the globe rupture is one of the important factors, one of the important complications of ocular trauma. So minor to severe problem, as I said, you should have a good counseling of this patient, and primary repair is very important. So I have put one talk on this, that repair of rupture wound, starting from the cornea to the back, that is pole to pole repair of the globe as a first thing. And we have Dr. Falini with us, just he has arrived here. He is the first person who has given us this concept that you can go in for globe to globe, pole to pole repair to have a maximum visual outcome or the stability of the globe. Is it correct or not? Yeah. So, welcome, sir. So, as I said, that there are few things are lacking. A good epidemiology is required for this, for the study of prevalence of blindness, uniform protocol for the management, and training and fellowship, particularly in the ocular trauma, which is important. And final, on the data, on the management aspect should be available. And we should have an Indian eye trauma registry. So that is what I thought I should tell you in the introduction. And rest we have other speaker to tell you about that in detail of this condition. So I request Dr. Namrata Sharma. She has a lot of experience with the management of chemical injury, and she is going to tell us about the chemical injury of the cornea.